Hello, my name is Jacqueline Cosgrove, and I'm the health reporter at the Oklahoman. Joined with me today is Tracy Cook, the Executive Director of the National Alliance on Mental Illness Oklahoma Chapter, Commissioner Terry White at the State Department of Mental Health and Substance Abuse Services, Oklahoma County District Attorney David Prater, and Dr. Murali Krishna, who is an Oklahoma City psychiatrist who works at Integris Health. Today we're going to be discussing mental illness and addiction in Oklahoma. Thank you guys so much for joining us. You can follow along on the discussion by watching it on newsok.com/live and ask questions on Twitter using the hashtag #MHNOK. Starting off, I'd like to talk about stigma. It's brought up a lot when we're talking about mental illness, this whole misunderstanding about what mental illness is. I was curious from each of you how you see stigma play out day to day in the jobs that you do.
At NAMI, we have a helpline, and we take just under 30,000 inquiries a year from emails and things on social media and the phone. And what we find is, first of all, people don't even really understand what mental illness is. They think that it is psychosis. They think that it is things like schizophrenia. They don't realize that mental illnesses also include substance abuse, depression, anxiety disorders, and ADHD. So there's a big misconception about what mental illness is. I think the other thing that we see is that people are afraid to talk about it, and so they don't want to go to treatment. They really believe, whether it's from their culture or their upbringing or their community, that mental illness is a decision and not a disease.
Yeah, one thing you brought up a lot, Commissioner White, is that these are brain diseases, just like heart disease and diabetes are diseases of other organs in the body.
Yeah, I think it's really important that we get past this as a society, because when we talk about diabetes, disease of the pancreas, when we talk about asthma, disease of the lungs, when we talk about mental illness and addiction, we still have Oklahomans who think or wonder or speculate, isn't this really a choice? Couldn't they just stop using drugs or alcohol, even though they're physiologically and chemically addicted? Couldn't they just go to work when they're actually depressed and need treatment? And I think until we get past we think it's a decision and we're blaming people for having a disease, we don't do that with any other disease. And I think it results in a lot of people who don't seek help, who are afraid to talk about it, who are afraid to speak out. If I was wearing a pink ribbon, you would probably know I was supporting breast cancer awareness. We don't have that same kind of support and structure for people with mental illness and addiction due to that stigma.
Yeah, and I think one thing that people battle with in terms of choice, especially as relevant to the criminal justice system. I mean, people talk about the high rates of people with mental illnesses or who are in jail and prison, and I hear people sometimes say, well, they did the crime, and they don't really understand the role of choice in an illness, which I'm sure is something you hear, David Prater.
Yeah, definitely. You know, as we're trying to determine how to best address someone's criminal behavior, we really do need to rely on their disclosure to their defense lawyer and their disclosure to our team as to what it was that was really driving their criminal behavior. And many times, you're talking about stigma, they are afraid to even admit that they have a problem. Many times they don't understand that they have a problem, and that they're unable to really articulate what it is that they're experiencing. But the stigma really does cause a huge issue with that. But you know, you just need to look at the numbers in DOC. You have a total of 33% of those currently incarcerated in the Department of Corrections who exhibit significant mental health issues.
Wow.
And yeah, well, 30% of those men who are incarcerated are exhibiting those mental health issues, the symptoms, but 58% of the women are exhibiting those mental health symptoms. And so when you look at that as a driving force as to why people are being incarcerated, there's no real question as to why we're incarcerating so many women in this state. It's because they're dealing with trauma.
Right, and I've seen some research that talks about how women could be more likely to use drugs to deal with their trauma. That was something I saw when I was going and writing about women in prison.
A lot of self-medication.
Yeah. Dr. Krishna, I'm wondering, you know, one thing that relates to stigma is the length of time that it can take for a person to get diagnosed with a mental illness. I mean, there's some estimates it can be years and years from the first episode that they actually are diagnosed. How have you seen that play out in your practice?
In all aspects of my practice, I've seen that. For example, a person with panic disorder who is having recurring panic attacks, they go to, on the average, 12 different doctors before they get diagnosed as panic disorder. They go to ER with chest pains, they go to cardiologist, gastroenterologist, and many other specialties before they ever finally get the diagnosis of panic disorder, which is really a brain disorder. There's a certain part of the brain that becomes more sensitive, and activates the emergency alarm system. And there are medications and various therapies that influence the brain to control the disease, just like you would have for any other disease, gastric disease or diabetes or heart disease. The same or even better rates of recovery if they're treated properly. So this plays out all over medicine right now.
One thing that I wanted to talk about was, you know, it can be difficult for Oklahomans, especially low-income, uninsured adults, to receive quality, consistent care. I'm curious about what we can do as a state to better ensure that those residents get the same care that people with diabetes, people with cancer receive. Maybe that you could start us out, Commissioner.
Yeah, I think that one of the things we need to recognize is that it's a struggle even for people with resources. We just this week were on a call with a nurse from a community just south of here, large community, whose child, they have insurance and they are having a hard time accessing the intensity of services that they need. They're struggling and they're calling us. And as you know, we exist to serve those who have no means to pay and no resources. And so we're trying to work with this mom on a sliding scale so that she uses her dollars for it, so that we can use our dollars for those that have no means. But the way that our dollars are stretched, we only serve 1/3 of Oklahomans who need help. 2/3 go without help. 2/3. We run out of resources to provide the medicine, the therapies, all of the things that would help prevent them from ever having to cross the district attorney's desk. And I think part of the dilemma that we have when we look at this resource issue is resources are decided by our policymakers who understand this, but as long as the stigma exists with the public, people run for office on things like education, on roads, on tax structure. Very few people run for office with the most pressing public health issue, which is our brain health, which is mental illness and addiction that affects 1 out of every 4 of us. And so we've got to get to the point where this becomes a public health priority so that we have the resources to serve those in need much earlier and prevent many of these negative consequences.
We've got to require insurance parity as well. You know, in the criminal justice system, when we're trying to determine how best to deal with an offender, juvenile or an adult, many times we're trying to find placement for them and with alcohol or drug addiction issues or a straight up mental illness. And we find a bed, whatever, and we cannot find the ability or the resources to pay for it. And many times they'll have great health insurance that will take care of the other diseases of the body but not the brain diseases. And so we really do struggle with that in our office, trying to find coverage for those individuals that don't have the means to pay for it.
Let's talk about parity for a second for folks maybe who aren't familiar with that term. I know Oklahoma has its state law that passed a while back about parity, and then we've seen federal changes. Maybe one of you could kind of address what is parity and sort of how we're seeing that play out, because we had some very recent federal legislative changes.
Absolutely. So parity is this. Parity is when you have equality. So for instance, with my insurance right now, and I have private insurance, if I go to my doctor for a 10-minute visit, my doctor, my family practitioner, gets more money than my counselor gets for a 1-hour visit. That's not parity. That's not right. And so what we find is not only are many of our behavioral health professionals not taking insurance, right now they're starting to say, you know, it's not worth it to me. I'll do a sliding scale fee like was mentioned. We're finding that to find a provider in your network is very difficult because there's just this huge lack of professionals that really want to be able to take that insurance. And there's not equality. So yes, the law was passed. Yes, it's supposed to be that way, but my insurer is a large insurer of many, many, many people, and there's not parity on my plan. That's a big problem. It's not right.
Thank you for explaining that. I want to get into some of the reader questions. We appreciate you submitting them so very much. We have several. One question, this is probably for you, Commissioner White. What programs exist in Oklahoma that are focused on treating the first episode of psychosis?
So one of the exciting things that's happening in Oklahoma is that there's a lot of research that's come out around the opportunity at what sometimes is called first break, first episode of psychosis, to do some really well-matched services and intensive intervention then that can actually prevent ongoing psychosis or potentially a lifetime of dealing with the disease of schizophrenia. So we are refocusing as best we can our limited resources to ensure that we have dollars available for first episodes and that we are training our providers in what some of the best most cutting edge research is on early intervention. So this is going to be an exciting program to watch unfold over the next several years.
Yeah, because Congress just passed where that was supposed to be 5% of the funding from SAMHSA
The federal block grant
goes to,
exactly,
to first episode of psychosis. Around what age might a person have that first episode of psychosis?
Late teens, early 20s.
Okay.
When they go off to college, it usually happens. Extra stress and genetic predisposition and other factors play a role. It's so important for them to receive the treatment right up front, because there's so much prevention happens when you get the treatment right for the first episode, and also get education for themselves and the family and the people that care about them, and then follow up. Then they'll decrease their future episodes significantly if we deal with them right up front.
Right. I mean, you're talking about in terms of, a lot of people use cancer terms when talking about mental illness, talking about stage 1 rather than stage 4, which is what a lot of people get treated as, late stage 3, stage 4. So you're talking about treating, when it's just begun, and you can actually, help prevent some of that illness.
And also, secondary problems develop after they have the first episode. They lose their self-confidence, self-esteem, and their own sense of self-worth. And that causes problem for them in their education, in their occupations, in their relationships, and really a lot of long-term damage done if we don't deal with it first time.
That's right. Yeah, that's right. One of our someone asked in the Facebook group that we have, Oklahoma's Addiction and Mental Health Community, they asked, lately in news coverage, much has been made of blaming mental illness on unspeakable violent crimes. Because of how broad mental illness is, these broad terms can stigmatize everyone dealing with illness. How can you and your position end this unfair generalization?
One of the things that we talk about a lot that we try to share with individuals is that the fact is, when you look at the general population, between 5 and 8% will be violent at some point in their life. When you look at the population of persons with mental illness, it's between only 3 and 5%. It's less than the general population. However, when it does happen, it's often in more out of the norm or more bizarre ways, so it grabs headlines, there's lots of coverage. But what we know is the research is very clear that if we provide treatment for mental illness, and especially for addiction, we significantly decrease the chances of any time going out of that 3 to 5%, which again is less than the general population. And I think that the person who submitted the question is right on that. It does further the stigma when we think everyone with mental illness is a danger to us, when the fact is everyone with mental illness is you, it's me, it's our children, it's our brother or our sister, it's our coworker, and if we just provide treatment, it's much less likely that we'll ever see those headlines again.
Well, and people with mental illness are also more likely to be victimized.
Absolutely.
Much more likely to be victimized than,
And that's the big point. That sure is. That's a big point. When I was in private practice, what I found was the majority of my clients who were experiencing mental illness, they weren't violent. They were trying to adjust how they felt, and so they would get in trouble by trying to either use some stimulant to make them feel better or something to bring them down. They're constantly trying to adjust how they were feeling with illicit drugs, and so that's how they got in trouble. So I didn't have any violent offenders who were suffering from mental illness. I mean, the people that I dealt with were dealing with PTSD or other mental illness or brain disorders that were causing them to use alcohol or drugs.
I think the discussion also goes back to not only treatment but appropriate treatment. So for an individual that needs intensive outpatient treatment, it's very difficult to find that level of intensity. And when you're really, really sick, whether you have diabetes or cancer, sometimes you need a higher intensity of treatment. But if the insurance companies are not going to pay for that, if you can't afford it out of your pocket, it is next to impossible to actually access intensive outpatient treatment.
Yeah.
Jacqueline, I want to make a point. When people don't get treatment for their mental illness, these insurance companies or the public or the government or the corporations, they still are paying the price. A person with untreated depression has 400% likelihood of having a heart attack.
Wow.
A person with generalized anxiety disorder has 33% higher chance of having a stroke. And yet, we are so reluctant to get them appropriate treatment as a society, due to ignorance, in my opinion. It may not be even stigma, it may be ignorance. And we are paying a price still at a very high level.
I think the points that Dr. Christian and Tracy just made are critically important as we also talk about budgetary issues. Because what happens now in Oklahoma, both on the insurance side that Tracy just covered, but for those who need services that are in some way supported by the state. We are stretching our dollars so far that as we face budget cuts, which we are potentially facing, we have to decide, are we going to cut people out of services entirely, or are we going to reduce everyone's level of service so that we can try to keep, everyone in, but at a lower level? Well, when you reduce people to a lower level of care and they need intensive services, they need more and more and more because they're not able to get the level of care they need to recover. And when they recover, then they use less services. And so it is a real conundrum when we are an underfunded system of how do you apply those resources? Do you just cut people out altogether and hope that there's not bad consequences, knowing that there will be? Do you try to reach everyone? How do you approach this? And it is a real challenge.
Right. And we don't have this discussion about any other disease.
That's
there's not any other disease where we're having this conversation.
Right.
And that it's not right. It's absolutely not right.
And it's
On the average, a person with mental illness dies 25 years sooner than you and I. And same with addiction. They die 25 to 30 years minimum in Oklahoma earlier than you and I, because the brain inside is affecting every organ in the body, every cell in the body. It's aging the cells so much faster. Without treatment, that's what happens. We're paying a heavy price.
And what's so sad about that is recovery is possible for so many people. I heard someone the other day say, wait, someone can recover from schizophrenia? And I was like, yes, absolutely, absolutely. You probably know somebody who's in recovery for schizophrenia. They still have the disease, but they're living happily, just like someone that works at NAMI. She describes herself as living successfully with schizophrenia, which I love.
She does.
So one question, it's an email from a mother who has an adult child with a mental illness. She said, my biggest immediate concern is that I'm trapped in Oklahoma's poor mental health system. I'm not allowed by insurance companies to go out of state to a better facility unless all beds in the state facilities are full, which is not that difficult, but still an enormous delay in finding care, even in Oklahoma. I want to be able to take my child out of state to get better care without having to move, but I certainly will move away from my child's entire family, which will be traumatic in itself, in order to get my child the care that will keep her out of hospitals and probably out of the legal system. What can we do to change the Medicaid and insurance rules so that we can allow the option to seek better care out of state until we Oklahomans can pull ourselves out of the bottom of the pit? And I know just from context and talking with that woman's family that her child is an adult.
Well, let me brag on Terry and her group. Actually, the care that you get in Oklahoma is quite high. It's really good, but unfortunately, there are too few facilities and too few beds. That's really where we are in Oklahoma. You just can't find an open bed anywhere, and the ability to pay for that bed many times is just non-existent for many families. But if you look at the quality of care that people get when they get in the system, it's quite high. So I'll brag on her where she may not.
One of the #1 calls we get from families, whether we're talking about an adult child or a child that's under the age of 18, is residential care questions. And we don't have those options for families in the state, and that is something that many people do need, that again, that long-term or very intensive long-term treatment, and if you don't have access to that, it's difficult. We do a lot of referral at NAMI out of state. I have found just recently, actually, in some of the places in Missouri, Arkansas, and Kansas that we call typically, that are no longer taking Sooner Care. And last year they did. And this year they're not taking referrals from Oklahoma for Sooner Care anyway. So it's getting, I think, more difficult instead of better when it comes to out of state at this point.
Sooner Care being Medicaid in Oklahoma. One of the continued challenges, and I know that it's hard for people to hear this message sometimes over and over because they feel a little bit helpless, but it does come back to resources. The Medicaid rates that are funded in Oklahoma are significantly lower than the Medicaid rates in surrounding states and nationally. We're funded overall 46th per capita. Compared to every state in the nation, we have the 46th lowest level of funding. We have the second highest rate of mental illness in the United States here in Oklahoma, which isn't surprising because we're a very unhealthy population. We have high rates of all diseases. We have some of the lowest Medicaid funding in terms of the rates, and so we have providers that won't take Medicaid in-state and out of state. And so I can hear the frustration in that mother's voice, and I think the biggest challenge is if we don't commit the resources to pay the rates that these doctors deserve to be paid. In the example Tracy gave earlier, the counselor who spends an hour is paid less than the primary care physician who spends 10 minutes. It's hard for people to go into this business sometimes in Oklahoma, but I appreciate what David said, or our district attorney said, because the providers out there, most of our network is a private nonprofit network across Oklahoma who do deliver excellent, excellent services. It's not me delivering the services, and so I appreciate them, David bragging on them, but I will brag on them. They dedicate their lives and get paid very little for the work that they do. But to get more people into this field, we have to pay appropriate rates.
And it's right, what you said earlier is we are paying. We are paying in other ways for whether it's this young man or a child. I mean, we are paying whether that child or person is in school. Are they missing out on employment opportunities? What does the home, I mean, what has happened in the home? The effect goes far beyond the person, and anybody that's lived in that knows it affects the entire family and the community. So we are paying for it. It's just
it's a cost of
unfortunate.
incarceration. Obviously, that's what everyone seemingly wants to talk about, but it's a cost of human capital. I mean, we're talking about human lives that we can effectively alter the course from negative to very positive. And at some point we're going to have to pull back and look at a long-term impact study and actually pay attention to what we know is true. And that is, if we would adjust the money that we're paying on the back end of people's lives to incarcerate them and move it to the front end and treat their brain disease, we wouldn't even have people entering the pipeline to go to prison. I hope someday I'll be put out of a job, but frankly I know that's not going to happen because the legislature never changes. They do the same thing over and over and over and want to magically believe that something's going to change. We've got to move those dollars from the back end of people's lives and adjust them to the front end and look at long-term effect and long-term investment.
That's actually our next question, is what is the discussion around individuals in our justice system and utilizing treatment instead of jail or prison?
Well,
so, I'm going to brag on David for a second, actually. In the Oklahoma City metro area, we do not have everything we need. We're still underfunded, but our district attorney has put together some amazing diversion programs. Our veterans diversion program, our drug courts, our mental health courts. He's a participant in day reporting, which is an opportunity for people to engage in treatment before their final sentence to see what that outcome will be. There are amazing opportunities for diversion, all of which are less costly than the cost of incarceration, all of which are less costly. The dilemma that we have is that, one, and for example, our district attorney has said to me now, we're probably going on year 4, where he has asked, can you get me more slots for my mental health court? I'm capped at 50 people in Oklahoma County's mental health court. Wow. And I am desperately trying to get him money through our Smart on Crime request to expand the size of his court. Also, his partners. There are only 16 mental health courts in Oklahoma, so 16 counties that have mental health courts. 17 other district attorneys, maybe not just like David, because I'm a huge David Prater fan, but just like David, who said, can I get a mental health court? So I have our district attorney in Oklahoma County desperately needing to expand. I have 17 other district attorneys who are actively begging for a mental health court, and there are many more than that who would really like to have one. When we don't have those resources available, they go to prison, but there are opportunities. And so I'll let David talk a little bit about his programs, but we're doing some amazing things.
Well, I just want to jump in real quick and point out to people very clearly that that means that you can live in County A and County B and commit the same crime as, let's say, your cousin, because everyone in Oklahoma has a lot of cousins, and you commit the same crime as your cousin. You both have mental illnesses, and your cousin lives in Oklahoma County, gets to go to mental health court, but you live in a county without a mental health court, and you will go to prison for the same crime, same illness. That's right. I just wanted to point that out.
Well, anecdotally, sure, that's true. I mean, and it is fair. It is unfair because if you live in a certain region of Oklahoma, you're going to be treated disparately from being treated in the metropolitan areas where we have greater resources for treatment. But I mean, I'll just repeat what I said earlier. I really do believe that we could prevent probably half of the people that we incarcerate right now from ever entering the criminal justice system if we were to provide adequate and appropriate treatment to them at a younger age. And then, once they do become incarcerated, I believe that we incarcerate people for too long because we're not funding appropriate treatment behind the walls. We need to provide appropriate mental health and substance abuse treatment behind the walls at DOC to get people out earlier. Let's just incarcerate them long enough to help get them well or better, and then try to reintegrate them with the appropriate services back into the community. Where we miss again as well is when your time's up, you get kicked in the bottom and they kick you out the door and say, good luck with that. Well, we don't provide reintegration services back in the community to help people with job training, to help them with sober living opportunities, and to provide them with the treatment and the support that they need when they're back out in the community, and you're setting them up for failure. So on every side of the criminal justice system, we're failing many of our citizens who are suffering.
I think it needs to be said too that if we did right now, if today we took that funding and moved it to the front, or didn't move it, and we said, you know what, this group of folks that are in jail right now really need treatment instead of jail, there's nowhere to send them. And that's where when he's talking about moving that funding, because we have to create that treatment, we have to create a place for them to go, because right now we don't have anywhere for them to go. In our office, we get probably almost one call every day from a loved one that says, my loved one is incarcerated in jail, was picked up yesterday for whatever, and they have a history of mental illness. And the first thing we ask is, what county are they incarcerated in? And I hate that that has to be the first question, but it's always the first question that me and my staff ask, because it matters. It matters where you get picked up.
One question that we got from a viewer was, what are the concerns about the current industry push to pass new convenience and profit-focused alcohol laws, like alcohol in grocery stores, getting rid of low-point beer, that sort of thing? What are your concerns about in terms of changing Oklahoma's alcohol laws?
I actually think this may be one of the largest or most important decisions that we deal with on alcohol for the next several decades. There are multiple proposals on the table. We don't know what the final proposal is going to look like, so it's hard for me to say exactly what the implications are. But the good news is we have been recently invited to the table from the public health side of things. We know that law enforcement needs to be invited to the table, because when we change our alcohol laws, when we increase access locations, outlet density, hours of sale, days of sale, concentration of alcohol, and most importantly, youth access opportunities. Because youth have better access to alcohol in certain locations than they do in others that are very well regulated. We know that we see increases in DUIs. We know that we see increases in those who need treatment for a system that is already overflowing and full. And so we need to think very carefully about, is this law that we keep calling modernization is really clearly a law of convenience. This is about convenience, and we need to decide what are the costs we're willing to give up for convenience, and ensure that if we're going to do this, we do so very thoughtfully and very carefully.
Dr. Krishna, could you talk about, there's a myth out there that it's safe for youth to drink alcohol at certain levels, and as long as it's at home, it's a controlled space. But can you talk about sort of, you know, what happens in the brain and in the development years, and when alcohol is introduced, what can happen?
When you take either alcohol or tobacco or any addictive substance at an early age, the brain gets kindled into developing addiction with more propensity later on in life. It's very important for the parents and the teachers and society at large to really teach our youngsters not to try alcohol, not to do drugs. And the later they try, the better off they are, you know, as they grow up. The earlier they try, the more kindling that they'll have. There's clear evidence at a molecular level that's what happens.
Our next question is about prescription drug abuse, and the question is, what can be done to stop prescription drug abuse for those who have mental health issues? You're shaking your head.
Everybody's looking at you.
That's a massive undertaking, but not one that we're walking away from. We try to be as aggressive as we possibly can in our investigation of prescription drug abuse, and really, the offender, you know, the person who actually has the addiction, those aren't the ones we like to focus on. We'd rather get them help so they, you know, we can help them, you know, move away from their addiction. But it's really the docs that are out there, and it's a small percentage, as we all know. But that small percentage of doctors are prescribing, over prescribing massive amounts of opiates and other very destructive drugs that, you know, were designed for good, but they're not being used in a good way. So law enforcement's attempting to be very aggressive as we deal with doctors and pharmacies that tend to prescribe and dispense the the drugs. But it's the largest problem. It's the largest problem that we deal with in so many areas, because when you can't get your opiates anymore, you start to use heroin, and we're seeing a great deal of heroin overdoses as well for young kids who can no longer go get the OxyContin or whatever it might be out of mom and dad's medicine chest, and horribly destructive. It's just a horribly destructive situation, and so dangerous.
The good news is I think that there are multiple people who've come together as a part of our statewide prescription drug task force, part of takeasprescribed.org. If your viewers and listeners haven't seen it, it is a website that has multiple resources on it that is trying to combat this issue, because for every 100 citizens in Oklahoma, 128 prescriptions were written for painkillers, powerful painkillers, 2 years ago. We have the 4th highest prescribing rate in the United States, 4th highest prescribing rate for hydrocodone, oxycodone, OxyContin. The good news is our physician partners are working and are in the process of adopting prescribing guidelines to hopefully make more clear and provide more information to physicians about when are those painkillers most appropriate, and when is that something to be cautionary about. We have partnership with our law enforcement partners, the Bureau of Narcotics, who have one of the most advanced prescription drug monitoring real-time systems where physicians can check the system prior to prescribing. We were able last year to reach an agreement between the physicians and those of us working in the prevention and law enforcement field that system will now is required to be checked before you write an initial prescription for a patient and every 6 months thereafter, to try to ensure that we significantly lower the rates of prescription drug overdose in Oklahoma.
Similarly, sleep medication abuse is also rampant in the whole country. There are over 70 million sleep medication prescriptions given in this country per year.
Wow.
Last time I checked. And if you carefully look at them, 85% of them could be taken out, those sleep medications, if they had education for a few hours as to how to sleep normally, physiologically healthy.
One question, I'm going to kind of combine some questions because we're running close on time. There's been discussion about the huge budget deficit that the state of Oklahoma might face, some estimates up to $1 billion with a B. And one person asked about how can we let our legislators know that mental health and addiction services are a must. And I know that part of the conversation, particularly for this legislative year, there's a hearing coming up on it, is assisted outpatient therapy, which is, I'll let you guys explain what that is. But I know that will be part of the conversation as well, with legislation being pushed by mental health advocates. So I'm curious about, how do you balance a budget shortfall year and then also being innovative and having those discussions about what's next and what can we better do to keep people from going to jails and prisons?
If you want to explain what assisted outpatient therapy is, and then I can talk about the funding related to it, though.
Okay. Before I go there, I think one of the questions was, what do we do? People have got to talk about this issue. We've got to contact our policymakers. We have a 1-800 number. Go to NAMIOklahoma.org, get our 1-800 number, we are really building a movement across the state right now, because we have got to get them on board. Just like you were saying earlier, we've got to move that funding. It goes back to the most basic human needs of, food and water and health and a shelter, roof over your head. We've got to look at those things before we look at all of these other things. And I hate to think that, not having potholes in my road and those things are luxuries, but right now they may be luxuries for us. So with that being said, AOT is assisted outpatient treatment, and that is where a person is mandated to treatment because they've ended up in that, I call it the corrections pipeline. But a judge can actually say, you know what, you're going to go to treatment for whatever length of time is appropriate, and this is what you're going to do. And if you don't do that, then there's going to be these other consequences. So it's something that we already have in our state. Unfortunately, it doesn't get used nearly enough as it should be.
So assisted outpatient treatment currently in Oklahoma is only available to be ordered by a judge if you've been in an inpatient psychiatric unit. And it is not, part of the dilemma that we have is currently the way you get into the mental health system is that you're really ill. You're acutely sick. You've reached the point where you're suicidal, potentially a danger to someone else, and then you can get in. So that's who's in our system right now. If we were to create assisted outpatient treatment, which I think is a really important program that we need to have in Oklahoma on a much broader level, it would order more people into treatment. Well, that would force, without additional funding, people out who are already very at risk. So the problem that I keep trying to figure out how to explain to policymakers is when, for decades, it is not current policymakers' fault. Our governor has been very supportive of mental health and substance abuse services. We have some champions in the legislature, some. But we have decades of underfunding, and I mean decades. I think hopefully you'll be talking about that in the near future, about how long we've been at the bottom of the barrel for our per capita funding. So they've inherited this system that now we have to ask, how important is it to Oklahomans that we fix it? How important is it that we even get to the median per capita funding in the nation, even though we have the second highest rate of mental illness? How important is it that we create opportunities for our district attorneys to actually have places and our judges to send people that doesn't force someone else who's very ill out in order to get that person in? And those are some of the dialogues that we need to have, and it is going to require everyone to get involved, because our legislature and our governor are going to have very tough choices to make this year. If they're facing $1 billion shortfall, it is going to be a painful year. And keeping Oklahomans alive, in my opinion, ought to be at the top of that list, and that's where mental health and substance abuse services comes in.
Yeah, no better time to really prioritize what's really important to you in this state. I mean, in a horrible budget year that everyone is forecasting. Let's figure out really what we care about in this state. You know, stop talking about it. Let's do it and figure out what that is. This is the best time, and we have to do. You know, we have to think long-term stuff. This can't be things that can be turned around in an election cycle. Unfortunately, you know, state reps want to look at something they can do in 2 years, and senators want to look at something they can do in 4 years. Well, we're talking 5, 10, 15, 20, 25 years when we're really going to see an effective policy, the effect of good policy changes now. And you just have to do that as a responsible policymaker, a responsible legislator, whomever we're talking about. But this is long-term stuff. This isn't short-term stuff. But no better time than now, because if not now, it'll never happen.
Yeah, I actually, and Commissioner White alluded to this, I found in our archives where 80 years ago there was a report that said it ended with if Oklahoma doesn't address how to best treat people with mental illnesses, it cannot look on itself with pride until it does that. That was 80 years ago. And it was an article that was published 10 years later, 70 years ago, talking about the low rate of funding. So it is true that truly for decades we've been talking about this, and I think that there's a large concern about what happens if we continue to not do that for decades. We're almost out of time. Luckily, we only have a few more questions. This was sent in for Dr. Krishna. What is being done to make sure patients who are discharged from a mental health facility are ready to live on the outside? Are they given coping skills so they are able to function outside of a facility?
Usually, most of the well-run mental health facilities, they have discharge planning, whereby they have an appointment with a doctor, get their medication, and they have an appointment with a therapist or a counselor or a community counseling center where they could receive their continued treatment. So there's fallback mechanisms are set into place before they're discharged from the hospital, and that's what's done. Unfortunately, sometimes they can't get in to see the doctor soon enough. Many people are booked up for several weeks at a time. So there are some gaps there in Oklahoma. We have some significant problems in the availability of mental health professionals and physicians also.
Can I also like to add just the environmental factor, because whenever, let's say it's my child, and they go to residential care or a crisis center and then acute care and come home, but if the environment hasn't changed at home, you are more likely to slip back as well. So education for the families and those loved ones is key to recovery. And then the education that we provide at NAMI Oklahoma isn't about the individual themselves. It's not about changing them. It's about changing you, so that you understand the illness. You understand how to talk to that person, how to help that person. You understand how to do self-care. And so that is just as important, in my opinion, as treatment itself. We have to continue to educate people in Oklahoma about mental health and how to, if they need to do certain things in their environment, in their home, to make it more conducive to recovery, those things need to happen. And so that's something I'm very passionate about, obviously.
One of the exciting things that's about to happen in healthcare is called population health control. It is so exciting because the concept is your entire incentive is to keep people well, and to have a cohesive, connected care for these individuals. So there are networks forming right now, and they're already being practiced in some areas of medicine, and it will come to mental health and psychiatry also in the next few years, whereby we have a very connected care Right now it's a little bit disjointed. You know, the care is done in the hospital may not necessarily have an outpatient facility or a doctor available to treat them following the discharge. So those will be connected when you're incentivized as health systems to really keep people healthy out there. I'm really excited about the development nationally.
One of our last questions is, it was about families, and it was for Tracy, but others can chime in. How can friends in the community reach out and help someone suffering from mental illness if they don't want it?
And we get that call every week too. I think what I tell people is, if you can't help them right now, you need to help you. So going to one of our education classes, learning. We have family to family. It's an evidence-based practice. Everything we offer is free. If it's a child, go to our NAMI Basics class. Learn about mental illness. Learn. Educate yourself. And if you are struggling yourself because of what your friend or family member is going through, go to counseling yourself. And we help people every week find affordable places that they can go, either with insurance or without, to get care. So if you can't help them right now, sometimes just learning about the illness will help you to figure out how to help if you don't know how, and sometimes you just have to wait for that moment.
What about
Jacqueline? I want to make a point before we close today.
Sure.
That Oklahomans have something very good going on right now that probably most states don't have. We may have less funding, we may have less education, we may have more stigma, but we have some of the most articulate human beings heading our agency, like Commissioner White, that is representing the mentally ill and their causes in a very articulate, coherent way to legislators, to businessmen, and to community at large. Kelly Fry, the editor of Oklahoman, and yourself and other reporters have done a wonderful job. I have not seen in any other state such an effort being made at a multi-level like we're doing in Oklahoma, and that'll produce results. I have no doubt in my mind. 5 years from now, 10 years from now, will be much better where we are from now.
Yeah, thank you for that. I guess one question we had, just probably will be the last one, in terms of suicide prevention. You know, suicide is something that people feel like they can't bring up because then the person will, die by suicide. Like they think they would just talk about it, it'll cause someone to do that act, which research has shown is not the case. If someone has a loved one that they are worried about is suicidal, what are some actions that they can take to better prepare themselves to handle that situation? Go ahead.
The simplest thing, and we can talk about this for an entire whole segment, right, because we have one of the highest rates of suicide in the nation, because we have all of the other issues we've talked about. But suicide is a preventable cause of death. There's a lot of mythology that's developed around the issue of suicide. Like you just said, if you ask about it, it makes it more likely to happen. It's absolute baloney. One of the things that is also mythology is if someone's thinking about suicide, there's nothing you can do to stop them. That is also proven over and over through research that is also baloney. So the simplest thing I can say is ask someone, if you are worried, ask the question that makes all of us uncomfortable. Are you thinking of killing yourself? Are you thinking about suicide? And dial 211. It gets you to the suicide hotline. If you'd like to remember the longer number, it's 1-800-273-TALK. But dial 211, and there is 24/7 people on the end of that phone who know what to do. They know how to talk to someone just to help talk to them, to be a consultant. They know how to get people who are trained in emergency response to the location that person is, if that's what's needed. They know the answer. You don't have to know the answer. This is a layperson's intervention. You dial 211. This isn't what I train our mental health clinicians. This is for the mom and the dad, the brother, the sister, the coworker, anyone out there. Call 211 and get that person on the phone with them.
And you can even call 211 if they're not even at the point where it's a crisis yet. That's
Absolutely.
one thing I think people don't realize is you can call 211. You can do a conference call where it's you on the phone and your loved one on the phone. They're very creative. I've watched them do it. It's incredible work. So
I think the key is to do something.
right.
I mean, you've got to do something. Don't ignore it. Don't act like it's going to go away. Whether your loved one is talking about it, or loved one or friend is talking about it, or not, or you're sensing something. Do something. Just do something. And like Terry said, the most uncomfortable thing you'll ever do is sit your friend down and say, "Listen, I'm concerned about you. Are you thinking about killing yourself?" Do something. Don't ignore it. It's too late if you do.
And you can find the warning signs for if someone's suicidal on the National Suicide Prevention Lifeline website. And So, well, I really appreciate each of you being here. I know you're each individually very busy people, but this has been a wonderful discussion. I really enjoyed it. Is there anything that any of you would like to say in closing that we haven't covered, or a thought you'd like to wrap up? If someone's got something.
I think mentally ill should feel proud to get treatment. We should not feel ashamed. It's a disorder of the brain, another organ of the body, probably the most important organ of the body. And we have wonderful treatments right now, and newer treatments are coming, and new understandings are happening right now. So it's an exciting time to be, working with mentally ill and getting treatment.
And if you are mentally ill, or you're a family member of someone who's suffering from mental illness, you are not alone. There are a lot more people like you than they are not. I promise you that. You are not alone.
Yeah. I think the most important thing we can do is people need to get involved. People need to talk to one another about this. They need to talk about it in their families. They need to talk about it in their workplace, because 1 out of every 4 of us, which means our coworkers, our businesses, to be as healthy and productive and economically viable as they can be, we all need to be talking about it. And ultimately, as Tracy said earlier, I hope that translates into talking to policymakers so that we have the ability to become the nation's leader in mental health treatment and recovery, as opposed to the nation's leader in the number of people struggling and not getting help.
Yeah, I have to just kind of, piggyback on what Terry said, is we join the movement. There is a movement right now, and we need everyone that cares about this issue. And like you said, everyone is touched. Everyone is touched by this issue, to understand what mental illness and addiction really look like, to understand what to do. Educate yourself and join with us.
Yeah, and another way that you can join the conversation is by joining our Facebook group, Oklahoma's Addiction and Mental Health Community. You can find that by going to facebook.com/groups/OKMentalHealth. There are more than 900 people in that group, most of them from Oklahoma, and we talk about mental health and addiction on a regular basis, today included. Well, thank you guys so much for joining us, and thank you for your wonderful questions and your involvement on Twitter and other social media channels. We appreciate you joining us, so thank you.
Thank you.
Thank you.
Thank you.